Hi, and welcome back to the POLITICO Health Care Summit. Before we get on to our next panel, I want to just share a piece that was just published like 10 minutes ago on politico.eu, and it's about a survey by the Pew Research Center, and it found that the public perception of the European Union has improved over the course of the coronavirus pandemic. We report that in 8 EU countries, people approved not only of their national government's response to COVID-19, but also to how the EU handled the outbreak, and also notes that in the UK, more people approved of the EU's handling of the pandemic than their own country. So that is very fascinating. This session maybe is gonna focus on the things that didn't go so well, but what we're learning from them. We're looking at lessons learned from the pandemic. So before I get into it, let me tell you to please submit your questions. You can find the link to the appropriate app on the event website. And this is also an opportunity to respond to our poll, which is presented by Lily, and it's live now. Let me get into to the questions for our panelists, and I'm going to start off with John Ryan, who's the Director of Public Health for DG Santé. I am massively truncating his title here. I hope you will forgive me. But John, I'm going to start on a slightly different topic. We saw today that the cancer plan, which is a big priority of the EU, we thought it was going to come out in December. It's no longer on the college agenda. Can you give us any updates on what's going on with the Beating Cancer plan?
Yes, so good afternoon, everybody. The Europe Beating Cancer plan is in an advanced stage of preparation. However, because the focus of the college at the moment is the ongoing pandemic and the response measures for the pandemic, we have decided to postpone for some weeks the Your Beating Cancer plan. So it's not cancelled, it's not delayed for any long time, it's just fixing a suitable date in line with our priorities of the pandemic. Thank you.
Yeah, and that captures the theme that maybe we'll touch on more here is care for other diseases falling by the wayside a little bit as we respond to the pandemic. But John, I'll stick with you. The Commission did just put out a package of lessons learned and proposals for how the EU can work better together in the future. Can you give us just kind of the 90-second top line version of what's in that for people who have not been following it closely?
So the package which we put forward on improving health security had 3 components. First of all, a revision of a decision which was adopted in 2013. And I can go into more detail on the changes that were made there, but also the mandates of the European Medicines Agency and the European Centre for Disease Prevention and Control were also modified. The idea of putting all of these 3 proposals together at the same time to the Council and the Parliament is to ensure that there's a close linkage between these 3 aspects, because if you look back, you will see that these 3 legal texts, which were already there for the European Centre for Disease Prevention and Control, the European Medicines Agency, and cross-border health threats, were all adopted at different times. And that's significant because, of course, it's important to have this linkage between the 3 texts. And go into some more detail on that later, maybe.
Okay, and Maurizio Ciccone, you are the head of the Department of Anesthesia and Intensive Care Medicine at the Humanitas Research Hospital in Milan and the president-elect of the European Society of Intensive Care Medicine. ICU doctors and health specialists have obviously been the hardest hit. I think it's fair to say. And many of the lockdowns that we've gone into have been, to deal with ICU capacity. From your perspective, have we learned any lessons between the kind of first emergence of the pandemic and now as we're in what some might call the second wave?
Yes, hello everyone. I would say just reiterating probably one of the key messages is that really one of the biggest problem is the amount of patients that could come at once in our intensive care. And normally in Europe there is a variability in the number of ICU beds. It goes from 4 to 25 roughly every 100,000 people. But normally on the organization of the services in winter that could be occupied 85% of these beds. So the key message is to look at the data of the spread of the disease in the community. And everyone is looking at us in intensive care, but the reality, I think we are the last line of defense. And the key message is really to try to control the spread of the virus in the community. That's where the attack of this virus is. And we need to look at the data. And probably a key learning for me has been that the world now during a pandemic is already too late. Really, we need to look at the data, and when you see that the virus starts to spread exponentially, you really have to put public health measures in place. Citizens in this sense have been helping us a lot by having compliance to face masks, hand washing, social distancing. This is really what's helping us a lot to give intensive care to everyone, COVID and non-COVID.
Thank you. And Kaisa Immonen, you are the Director of Policy for the European Patients Forum. First, can you give me a bit of your reaction to the Commission's lessons learned package? Will that help? And what are some of the main areas where non-coronavirus patients are kind of struggling with the pandemic?
Absolutely. Thank you. Thank you for the question. Well, the Commission's package, obviously I work for a European level umbrella patients organization, so we have members everywhere across the EU and European region. The Commission's proposal are obviously positive. We have welcomed them. They should be seen, I think, as a starting point to build better healthcare systems. In our thinking, health security goes beyond crisis preparedness and cross-border threats. And the basic healthcare provision and its capacity to continue even in the crisis needs to be definitely considered. And this is partly mentioned in the plans, of course, but I think we will need to have further reflections on this. The European Health Union proposal should be, in a way, a wider framework that will give the right resources and instruments to address those systemic challenges, such as access to care and the quality of care, but also digitalization, health inequalities, health literacy, and tackling both non-communicable and communicable diseases alike. We've seen challenges, obviously, from a patient perspective, it's becoming clear that one of the most detrimental impacts of the pandemic has been on disruption of other services. So, for example, screenings, diagnostics, delayed appointments, and many healthcare systems are experiencing a backlog in this. For example, in Finland, it has been estimated that this year in August, there were 15,000 more patients waiting for treatment than the previous year. And the health authorities there across the different regions have said it will take maybe even until 2022 to normalize the situation. So the excess toll in terms of death, illness, and quality of life is still really being counted.
Right, and that's quite striking in Finland, which is a country that I think is generally seen as having handled the actual pandemic itself very well. So thank you for that example. Tim Garnett, as the Chief Medical Officer of Lilly, how is this affecting work on clinical trials and research for other treatments for other conditions that you might normally be focusing on?
Well, good morning from Chicago. Good afternoon to all of those in Europe. Pleasure to be here today. There's been a number of impacts of the COVID pandemic on our clinical trial activities. And I would say in the short term, they've been quite challenging, but I think in the long term offer us a very real opportunity. For example, in our clinical trials, we've moved to virtual visits rather than patients having to attend hospitals. We've been able to run virtually all of our clinical trials in a virtual manner. We've shipped drug direct to patients rather than go to pharmacies or to their clinical trial investigator center. And we've been more flexible with the windows in which people can come in for their visits if they need to. I think these are all things that actually we need to learn from and carry forward in the future, because I think there are opportunities to learn and do clinical trials differently in a way that can be much more patient-centric, much more patient-friendly, and in doing so, encourage people to enroll in clinical trials across all therapeutic areas. And again, one of the unlooked for benefits of the pandemic is that it's raised awareness of clinical trials in a way that we've never seen before. So many people enrolling in the vaccine studies across the globe and participating in a way that's not happened previously. So I think we need to use this head of steam, as it were, to learn not only how to encourage people to participate, but to make that participation easier for them. I think a second theme there would be that of diversity in clinical trials. It became very clear at the beginning of all the clinical trials on COVID that the disease itself was disproportionately impacting certain communities, but generally minority communities, disadvantaged communities who had less access to healthcare. And of course, with the resurgence or the emergence rather of the Black Lives Matter movement in the US and in other countries as well, I think it's focused on disparities of healthcare access and social justice. So I think this is going to give us an opportunity to really focus on ensuring going forward that our clinical trials in all therapeutic areas actually reflect the patients who are going to receive our medications. This is not a new issue, but it's one we've struggled with for many years and across different therapeutic areas. And I think we need to use this crisis to ensure that we actually do improve the representation of patients in our studies.
Tim, I really appreciate you making that point, and we have heard about this issue a bit in the United States, in the UK to some extent. In continental Europe, sometimes dealing with diversity can be a bit more of a complicated issue. Some countries don't even have data on it. I mean, what is your sense of how continental Europe is? Are some countries dealing with this, or is it mostly something that's being ignored for right now?
Well, I think our focus in the short term has been a little bit more US orientated, I will admit. Partly we're a US company, but also the Black Lives Matter initiative really started in the US. But I don't think this is a US issue or a UK issue. I think across all countries in Europe, we don't have good representation in our clinical trials of minority populations. That's partly for reasons that, from a pharma perspective, we can't impact, in other words, access to healthcare, which maybe is not equitable across societies. But there are things that we can do to make sure our clinical trials are materials, and the materials that advertise them are in multiple languages, to make sure that we recruit investigators who represent and come from the communities that we want to recruit, to make sure our clinical trial centers are in city centers and other urban areas where disadvantaged patients are maybe more likely to be and more likely to participate in clinical trials if they're close to them, to help patients get to clinics, to help with cost of travel, etc., to have study visits at times of the day that don't interrupt with their working hours. There's many things that we can do as a pharma industry to really impact this, and I don't think these are confined to the US. And certainly within Lilly, and I know other companies are working on this as a global approach to improve representation in our studies.
Mm-hmm. Thank you, Maurizio. Hospitals have become the testing ground for a lot of the treatments that we're dealing with, whether they are kind of formal clinical trials by drug makers, or if they're doctors who are just kind of trying to figure out the best practice. How has that played out in hospitals, and has that improved over the course of the pandemic? And are there things at the European level that we can do to make that sort of real life trial process go more smoothly?
I would say that especially at the beginning, in March, in April, there was a lot of anxiety from clinicians to try to find quick solutions. And I think a lot of drugs were tried there. We've learned a lot from it, especially in the sense that we've learned that probably since there is no specific therapy for COVID-19 yet, what pays better is probably to do simple things well for all patients. And in this sense, supportive care, which is what we do in intensive care, actually has decades of studies on how we can ventilate this patient, how we can give them time to rest, and so on. Studies have been instrumental in this sense because, for instance, we've discovered that some old drugs that we knew, like dexamethasone, thanks to the recovery trial and some other platforms that have been put together in some meta-analysis like REMAP-CAP and so on, there are ways basically of doing research fast even during a pandemic. And I think in this sense, as being a good learning from us, but what we have now really is the fact that probably we need to stick to what we know, realize that there are many things that we do not know, and trying to put together a research consortium, adaptive trial platforms to really try to study this as much as possible. Because I would say to complete this, that really, since it is a problem of a large number of patients that come to our units, what we really have to do is trying to find a sustainable way to scale up our intensive care in case there is a surge. And in this sense, maybe there has been too much emphasis on considering a ventilator and ICU bed. ICU beds are ICU people, are the doctors, the nurses that work there. The biggest challenge for us is not been finding the drugs or the technology, it's been finding a number of competent people that can actually come and work within our teams. And in this sense, I can elaborate a bit later. I think training of people not working regularly in intensive care is a key part of our answer in this wave, and maybe there will be other waves.
Mm-hmm. John, if you could react to that, are there things that can be done at the EU level to help both with trials as far as, you know, aligning data, which is certainly an issue that we've heard about in many other areas such as cancer as well as helping with training of health professionals?
Yes, so my colleagues who are responsible for...
We may have just lost you. All right. Oh, here you are. Okay.
On clinical trials, in fact. So apologies for that. In fact, the research program has been used quite intensively to support different therapeutic trials, but also our colleagues in the Joint Research Centre of the Commission have been supportive in publicising these trials and providing platforms for researchers and so on. So what we've tried to do is, as happened before with the Ebola outbreak, the last Ebola outbreak in Central Africa, was to try and mobilise our research resources, either existing research consortia or issuing new calls for proposals in a very short time frame. And a number of these projects are ongoing. My previous speaker was talking about, for example, the investigation of existing therapeutics, and our supercomputer colleagues who are working as well in part of the Commission in the Joint Research Centre have been mobilising their resources to try and identify potential molecules which could be used for treatment as well. So not just taking established treatments, but also exploring individual molecules for the development of treatment. And finally, I'd mention great interest at the moment in antibody therapies, and we're considering as well the possibility of launching joint procurement, as we've done for many other therapies, including remdesivir, for example, and also a whole palette of intensive care medicines, which the member states asked us to procure. So we're trying to activate all our levers, I would say, across the European Union budget, but also our different research institutes to react to this situation.
Well,
just on the final point,
please,
I would say, of course, the lesson learned for me is really to try and foresee these issues rather than react. I mentioned that we were reacting to a situation. We're in the middle of a pandemic, so it's normal that we react, but it's also normal, I think, that we try and foresee these situations. I can speak a little bit, perhaps, about our plans for reinforcement of this preparedness aspect later on.
Actually, please go ahead and continue now. I know that there have been some issues with not having great visibility of things like ICU beds or people in the member states, and I know that the Commission has some ambitions for how to deal with that.
So we did have a preparedness mechanism in place since 2013, where the member states were supposed to report on a number of indicators. And in this way, we were supposed to have a better overview, and member states were supposed to have a better overview between themselves of the state of preparedness, because I think even before our legislation was adopted in 2013, there was a recognition that these events were cross-border events, and that if a country did not have adequate preparedness arrangements in place, this could affect their neighbours and also the internal market. Now, on the international level, of course, this is also recognised in the international health regulations, which all member states have signed. So we tried to establish, first of all, in 2013, a bridge between the international health regulations, which are operated by WHO, and our own internal arrangements for the cross-border health threats. In practice, this system didn't work. This system of reporting didn't work adequately because in the implementation of the legislation, it became very much a paper exercise, I would say. And what it was lacking was a reality check. And I mean, we're living through a reality check at the moment, in fact, with what's going on in the member states with these first and second, and perhaps further waves. And this shows the importance of preparedness and investing in preparedness, not only in respect of intensive care beds, but also in terms of equipment, pharmaceutical therapeutic products, vaccines, if possible. And also, most importantly, perhaps what my colleague from Milan just mentioned, the investment in human capital, because there's no point in having 250 intensive care beds if you don't have the adequate staff to actually manage those beds. So all of this is linked, and this is why we were attempting in our proposal for a reinforced health security arrangement to look at all of these aspects in a holistic way, to look at the medical products aspects through the revision of the European Medicines Agency mandate, the same thing with the ECDC mandate, and the same thing as regards the relationship between the member states through the Health Security Committee. So all of these things are linked, and as I said in my introduction, the problem was in the past perhaps that these texts were introduced separately and in a silo approach. What we're trying to do now is to bring these ideas together.
Thank you. And Kajsa, one of the things, the motivations behind keeping health authority at the member state level, as opposed to giving the EU Brussels as much control over it, is that national politicians are closer to the citizens. They're more directly accountable to the citizens, and the more local you get, the more accountable they are, arguably. So for patients, what's kind of the calculation here? I mean, can we make broad statements about what patients want as far as whether the Brussels is holding their national politicians accountable, or do the patients and citizens in general want to, keep more of that power with their voting power?
Well, that's a good question. Obviously, healthcare is local, and it should be as close to the patient as possible. But we have worked with our patient community for many, many years, and we have consistently found that the concerns of patients as healthcare users, and I'm talking particularly about people with chronic conditions, are very similar. So there are certain fundamental principles such as person-centeredness, quality, safety, access that are similar, and where all countries or most countries are facing similar issues. Every European health system is looking at changing demographics, changing needs for healthcare. As a result, efforts to change healthcare systems into more person-centered ways and so on. And there are definitely learnings that should be shared across countries, and things that can be recommended for good practice and lead to more evidence-based policy and practice. And this is where really involving the patient community and healthcare user community is absolutely vital, both at the European level, but also then obviously at the local and national level to create those linkages. In this pandemic, for example, we have seen that the implementation of digital solutions has suddenly taken off in a very, very rapid way. But those tools have not been consistently available everywhere to all patients. And our members are telling us that they would really like to have a more equitable access to digital health, telemedicine, and other services for everyone. Also, we have the impression that the pandemic preparedness plans in many countries were designed without input from healthcare users, and they have resulted in certain unintentional adverse consequences. And it would make sense to collect patients' and healthcare users' perspectives to review those plans and make sure that in the future they work better. Just a small example, the sort of blanket application of visiting rules in many healthcare institutions has led to a situation where very ill and even dying patients were left alone because their family members were not allowed to visit. In Canada, a patient group has called for a distinction to be made between essential care partners, so the essential family members, and visitors. So obviously, this is something that would make a lot of sense to anyone, I think. And it's this kind of cross and transversal learnings that we should really be looking at when we look at improving our health systems.
Mm-hmm. Thank you for that. And that I think is an important lesson learned, that the sort of priority on infection control in an environment where we didn't know a lot maybe took precedence in a way that I think some people are looking back on and rethinking. Mauricio, is that something that you would like to weigh in on? Is that something that health professionals are sort of reconsidering now?
Yes, I would say, linking to what was just said, I would say one of the biggest difficulties for us as healthcare workers in intensive care in hospitals in general is being exactly this, the fact that we had to close hospitals, to visitors, to family. Family has become an integral part of the healing process. It's not just about having them close to our patients when they are not feeling well. And these had significant burdens because we felt a lot for our patients. Very often we were the last hand, touching our patients there. I think we need to rethink this, because while infection control and the spread of coronavirus is important, I think we are probably preventing a key part of the healing process of our patients in our hospitals. And definitely, I think what this pandemic has really taught us a lot is really this focus on people, patients, families, but also healthcare workers. I wanted to elaborate a little bit on what I was saying before about the training. I think one of the positive things of this pandemic was the fact that clinicians and scientists, they tried to share as much information as possible through webinars, through networks of clinicians and so on. We did a lot with the European Society of Intensive Care Medicine, and this led to meet, for instance, the clinician networks of the G-Santé of the European Commission. And through this exchange, we shared a lot of these things, a lot of the problems that our intensive care units faced in the first wave, which was not just ventilators and drugs, but exactly this. How can we find ways to speak with relatives, for instance? How can we find a way to surge with so many healthcare workers needed to increase ICU bed? And this focus on people, I think, led to a very important part of the preparedness, and we were very happy when the European Commission, the European Union, funded a training program for healthcare workers that never work in intensive care, that don't work regularly in intensive care, and that can come and join our teams. And indeed, this is called the C19 Space. It's basically COVID-19 skill preparation course. It has the ambition to train 10,000 professionals across member states. As I speak, I think we've enrolled about 7,000, equally split roughly between doctors and nurses. And it's about basic competence to come and feel comfortable in an intensive care team. And some of these competencies are indeed not just how to use a ventilator, how to care about syringe pumps, but is also how to understand the psychological burdens of our patients and how to be close to them.
Thank you. And we have about less than 10 minutes left, so just a reminder to the audience to submit your questions. I could keep asking questions for the next 2 hours, but I think my events team would get angry with me if I did that. But for now, I'm going to talk about one of my favorite things, pharma and medicines. John mentioned that the Commission has worked to jointly procure remdesivir, but that drug has become a bit controversial. There's some doubts about whether it actually works. So Maurizio, have you found that to be a valuable tool in your hospital?
So I speak for my hospital and for my intensive care. First of all, in Italy, it was not so easy to have the drug. So you had to ask a specific request to the centrally, basically to the government to get some of the drugs. So it was not so easy. Looking at evidence, I have to say it's not a drug that I use in intensive care that I would personally consider using in intensive care. And this is my position, and so it's not something that I started. But my position is also the fact that based on the evidence that we have so far, I didn't find any specific treatments to be started in intensive care. It does not mean that some treatment could not be started actually before intensive care. While if you're talking to me as the president-elect of ESIC, ESIC is actually participating in reviewing all the evidence around treatment and drugs and therapeutics for COVID-19 critical ill patients. We already published a guideline together with the Society of Critical Care Medicine in America with a campaign which is called the Surviving Sepsis campaign. And we are now working towards a new guideline. So we are reviewing all the evidence, we are grading the evidence, and we will come out with some recommendations around drug usage in intensive care.
Thank you. And Tim, Lilly is working on an antibody treatment, and please correct me if I'm wrong, but it's kind of been determined it's not so great for patients with very serious illness, but it may well be helpful early on. And my understanding is you're applying for an emergency use authorization with the US FDA. What can European patients expect as far as potential access to this treatment?
So the antibody we're developing, in fact, there's two. One can be used on its own, and then there's a combination antibody. The monotherapy, the antibody can be used on its own, has already been granted an emergency use authorization in the US and is already being used and distributed through the US government. We've had discussions with the EMEA about potential use in Europe, and also with individual member states as well, as the emergency use authorization equivalent in Europe really depends on individual states' rules rather than the EMEA rules. You're right, this is a drug for people who are at the very early stages of disease, and has been shown to reduce the probability of hospitalization. It's been studied along with the NIH. We studied it in patients who were already hospitalized and found that it didn't have a benefit. This was not a surprise to us, to be honest, because as an antibody, you were expected to have an impact at the early stages of disease, as opposed to undo the damage of disease that's already occurred. So that wasn't a surprise. But we do hope that either the monotherapy antibody or the combination antibody, which we've also applied for an emergency use authorization in the US, will be available to European patients through various different approval mechanisms in the near future.
So have you started any negotiations with the European Commission for some sort of joint purchase?
We're not. My role is really on the regulatory side, and so we'll be talking to the regulatory authorities. In terms of distribution, it will be with national governments rather than through the European Commission. So we've had discussions and will have discussions with individual governments once it is approved in their country about distribution, and we will be supplying the drug based on need. So we have a limited supply of the antibody, and we'll be distributing it globally when it's been approved based on the need in that individual country. And some countries are at a peak at the moment of a second or third wave. Others, such as China, have very few cases at the moment. So we would distribute it based on the rate of disease in the country.
And just to make sure I understand, so you're not pursuing the conditional marketing authorization route through the European Medicines Agency? We
are, but in parallel, we're talking to individual countries. So some countries, for example, France, maybe Spain, have what you would call an expanded or compassionate use program, which is a pathway that could actually get the drug to patients more quickly than the European conditional use approach.
Thanks. And John, are you aware of any requests from member countries to have the Commission help purchase the Lilly drug?
Yes.
You are aware of us. Can you provide any more details on that? Okay. We'll take what we can get, I guess. The compassionate use thing is something that is quite interesting to me, coming from my home country of the U.S. When we saw President Trump end up in the hospital, he received a competitor's antibody cocktail, and I believe New Jersey Governor Chris Christie received Lilly's treatment actually when he was hospitalized. And some people pointed out, hey, these are powerful politicians who are getting access to experimental treatments that not everybody else can get. And Tim, I'm wondering if that is a source of concern for you.
Well, it's not entirely true. We have a compassionate use program, also called an expanded access program, available for our monotherapy antibody, and we have provided it to patients or their carers who have requested it based on the medical condition. So when we receive a request, we make a decision based on the medical condition of the patient, whether they're at an appropriate stage of disease. As we mentioned earlier, the drug doesn't work in the later stages of disease, so we don't supply it in those circumstances. It works best or is most effective and most valuable in the elderly or patients with comorbid conditions. So when we receive a request, we fill it on the basis of merit, not on the basis of who that patient might be. And obviously, I can't comment on individual patients we may have treated. Now, there is a reality that when it comes to compassionate use or expanded access, knowledge and awareness of that is not equitable. And many people and many carers are not aware that companies like Lilly offer expanded access and compassionate use programs. So there is a disparity inherently in the healthcare system. But from Lilly's perspective, we respond to all requests and we fulfill requests based on the medical condition of the patient and on medical need. And we have fulfilled, before the emergency use authorization was granted, we fulfilled a number of requests in the US. Now that the emergency use authorization is granted in the US, we are no longer doing that. And the way to receive the drug is through the US government's distribution program.
Mm-hmm. Maurizio, is there a good way to make decisions at this point about who gets, once we kind of have these therapies, are you confident in the way we make decisions about who gets them when they're in short supply?
It's an important question. I actually think a key message that I would give to clinicians and to patients is that all these new treatments, everyone focuses on efficacy, but actually we don't know if they may cause harm as well. And I believe that the best way to find this, even during a pandemic, is to use the best scientific methods. So if we can do trials fast, and we demonstrated that we can do trials fast, we can provide very important evidence that can inform us about the efficacy and the safety of these drugs, and then we will know in which patient we can use the safely and hopefully improving their outcomes.
Thank you so much. We have 30 seconds left. Kaisa, I'm going to give you the last word.
On drugs?
Yes, and making decisions about who should get them when they're in short supply.
Well, look, there is not much to say. I support what Maurizio said about having the full evidence base available, first of all. But obviously, once they are available, we want them to be equitably distributed. And so they have to be also affordable. So the price will also matter. I don't want to comment on the US system, but in Europe, obviously the Commission is working to coordinate purchasing, and that's good. We need to make sure that there's appropriate transparency around this as well. Thank you.
All right, well, thank you so much to our panel. We hit on some really important points about non-COVID things that are kind of struggling during the pandemic, as well as touching on various different points about equitable access, whether it's inclusion in clinical trials or knowledge levels to people's access to information that can affect the level of treatment they get. So thanks so much to all of our panelists, and we look forward to hearing from more from you over the coming months. And we will be back in 10 minutes. Oh, and before we end, if we can display the results of our poll, please. And while we do that, I will tell you that we'll be back at 5:50, 10 to 6, for a conversation on the future of medical devices with my colleague, Jillian Deutsch. Thanks so much, everybody.